On the behalf of the American Heart Association, I would like to welcome you all today to today's Clinical Fundamentals of Pulmonary Embolism webinar. I'm Aliza Rizvi, Senior Program Manager at the American Heart Association, and I'll be your host today alongside Alexa Cohen, Program Consultant at the American Heart Association. Before we begin, let's take a quick second to go over how to use the platform for today's event. If you run into any technical issues, a simple web refresh often resolves most problems. If that doesn't help, please check out the system requirements or contact the Zoom webinar helpline to support. To access live closed captions, please click on the closed caption button found on your screen. Lastly, the recommendations and opinions presented by our guest speakers may not reflect the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by the Heart Association. The American Heart Association does not endorse any product or device. We have quite a packed agenda today, and throughout our discussion, you will have the opportunity to submit text questions for our presenters using the Q&A feature on our control panel. You can send in your questions at any time, and we'll do our best to review them during the Q&A at the end as time allows. Finally, this webinar will be recorded and available with the slide deck on the Target Pulmonary Embolism website within the coming weeks. This event is made possible through the American Heart Association Target Pulmonary Embolism Initiative, a 3-year initiative supported by Inari, now part of Stryker, that's designed to inform future evidence-based PE treatment options, create systems of care that help hospitals identify, triage, and treat all PE patients and mitigate known and unknown barriers to a PE system of care. This is the first webinar of our series, and we'll have several other educational events throughout the duration of this initiative, and we highly encourage you to visit the website using the QR code that you see on the screen to learn more. We'll also be dropping in the link in our chat box. Seen on the next slide are the 20 hospitals participating in this initiative and who are working towards improving PE care and patient outcomes while also creating a national framework for pulmonary embolism care. For additional information, we'd love to provide you all with some resources and the latest press release that we had for the Target PE initiative. We'll also be dropping that in our chat box too. With that, it is my pleasure to introduce Dr. Stephen Pugliese. Dr. Stephen Pugliese is a pulmonary and critical care physician with specialized expertise in pulmonary vascular disease, including pulmonary hypertension and acute and chronic PE. He serves as the director of the Pulmonary Embolism Response Team and Comprehensive PE Program Medical Director at Penn Med. In addition to his clinical and administrative roles, Dr. Pugliese is an associate professor of clinical medicine at the University of Pennsylvania and is deeply committed to teaching others about pulmonary vascular diseases. He's also one of the co-authors of the newly released 2026 AHA-ACC Pulmonary Embolism Guidelines. With that, please join me in welcoming Dr. Pugliese.
Aliza, thank you for that introduction. As she mentioned, the new AHA guidelines are available. They came out last month. There's a QR code to them. I'll say these are the first clinical practice guidelines specifically from the AHA and ACC on PE. And we're going to talk about a little bit of some of the information on the guidelines, but if I had to kind of summarize the major takeaways or major changes that were recommended in these guidelines, the big one that folks are talking about is an entirely new classification system for PE, which we're going to hear about tonight. There are some changes with regard to the level of evidence and the recommendations for some of the advanced therapies in PE. And there are some new recommendations regarding anticoagulation practices and follow-up care. So check those out. Again, QR code is there. Also, what I want to highlight on this page, there's a bunch of resources, and I looked through a couple of these, but what's really great is there's actually a slide set for PowerPoint that goes through the guidelines. So when you guys are giving talks and things like that, you can use these to discuss the guidelines to your teams, to your hospital, etc. And there's also some helpful information here for patients as well, which I found great. So take a look. All right, so I'm going to just spend a few minutes talking about epidemiology and pathophysiology and acute PE. Fortunately, this actually hasn't changed too much. I think many of you know that VTE is the third leading cause of cardiovascular death in the United States. A certain proportion of those patients will go on to develop CTEPH. A significant portion of those patients with PE will go on to develop functional limitation, ongoing shortness of breath that then becomes chronic. And this is a huge cost to the healthcare industry. I think what makes this interesting is how common it is. But think where we are with regard to stroke and MI care, which are the two other ones that are more common, with regard to acute care, with regard to major clinical publications on how we manage patients. And VTE, PE is much behind the eight ball in that, despite the fact that it is common. The incidence of PE is about 1 per million. And just to kind of put that into context, especially for those folks who take care of these patients, have outpatient clinics and take care of them, it's about as common as breast cancer. So it's very, very common. Again, if you think about putting those two diseases, if you think about how common breast cancer is and the amount of awareness and the amount of research dollars focused on that, versus PE. Again, very, very, very different. And they're also important, as you can imagine, there's very important racial disparities within PE. For instance, Black patients have a higher incidence and they have a higher morbidity and mortality. And there's other racial differences between outcomes in PE as well. And when we think about risk factors, we used to use this categories of provoked, unprovoked. That's kind of gone out of vogue, and really we term them major reversible risk factors, and that's mostly focuses on patients who've had PE or VT in the setting of surgery. We have our minor reversible risk factors, which are going to be things like hospitalization, estrogen exposure. And then we have our persistent risk factors. So those are patients with cancer. Those are patients with inflammatory diseases like autoimmune or inflammatory bowel disease. And then, one thing I think is probably under-recognized are these anatomic abnormalities. Thoracic outlet syndrome, that's relatively rare. May-Thurner, and particularly in young women, uterine fibroids, we know that they can cause venous compression and VTE. So everything else that is not one of these risk factors, we then lump them into unprovoked. And, a small percentage of these patients will have some type of hereditary thrombophilia. But what I tell patients is, these are the things you don't have any control over. So the older you are, the more likely you are to have a VTE. Men are more likely to have VTE than women. There actually is data suggesting that patients with non-O blood type are more likely to have VTE than other blood types. So with regard to pathophysiology, there's a lot going on more than clot. And so typically when we're thinking about like Birchall's triad, and there is typically some type of inflammatory insult, there's often venous stasis. This leads to cytokine release. The endothelial becomes dysfunctional. Platelets are activated. There's thrombogenesis. There's clot formation. And then in this entire inflammatory pathway, then that leads to often vasoconstriction in a variety of vessels. That leads to a systemic immune response, and then this feeds back and then fuels the fire, so to speak. And that's particularly important when we think about, particularly important when we think about the inflammatory response in patients with regard to things like RV afterload. Like for instance, um, only about 40% of the acute rise in RV afterload for PE is actually the clot. The rest is all inflammation. So this is actually a really important aspect of how patients do in acute PE. Obviously, there's going to lead to abnormalities in gas exchange. One of the major things that happen is that there is increased dead space, and that's literally defined by an area in the lung where you have no flow, but you have ventilation. And typically, increased dead space actually leads to increased CO2, but in patients with acute PE, their carbon dioxide is almost always low. And part of the reason is that it's an inflammatory state. They're often in pain. They're hyperventilating, and the rest of their lung is otherwise normal. So the CO2 is typically low unless it's something like a catastrophic pulmonary embolism. They get hypoxemic, and that is due to VQ mismatch. So if you have blood flow that is blocked from one vessel, it gets diverted to another vessel. And these area of the lung, it gets more blood flow than there is ventilation, and that's called VQ mismatch, and that leads to hypoxemia. Now that's typically mild, and we know that even patients that are pretty sick often only need a little bit of oxygen. But some patients can develop severe refractory hypoxemia. And when that happens, we're typically thinking about a patient opening up a intracardiac shunt like a PFO. This is rare, but can be quite severe. And so we talked about thromboinflammation, and this is kind of the classic downward spiral of death. So there is an acute PE, a rise in RV afterload, the right ventricle dilates. As the right ventricle dilates, it requires more oxygen. It then starts bowing into the left ventricle. That causes a decrease in cardiac output. Then blood pressure starts going down, causes further ischemia, and if that process left unchecked, the patient develops obstructive shock and dies. And so a lot of our focus on PE is identifying PE early and stopping this pathway of the quote downward spiral of death. And this is an example of a patient actually that can die two ways from pulmonary embolism. The first, as you can see, this is a patient who has a very severe blood clot. There is almost no flow that's able to go into the left side of the heart, which you can barely see here. So this is a patient who is at imminent risk of dying of progressive RV failure. But the other thing you'll notice kind of swirling around the right atrium here is a huge clot in transit. And so one of the other things that can happen without warning is even in a person with a normal right ventricle, this is the kind of the classic story of the patient goes up to go to the bathroom and they have a cardiac arrest. And often what's happening in that scenario is a clot is literally transiting from the lungs, from the legs, through the heart and imminently causing a cardiac arrest. All right, so now I'm going to pass this off to my colleague, Dr. Yallapragada, who is going to talk a lot more about all aspects of PE.
Thanks, Dr. Pugliese. That was a nice setup for this next part of the discussion. So I serve as the Chief of Cardiology at Medical City Heart Hospital in Dallas. I'm also the chair of the PERC Council for our division within the HSA section here in the DFW area. And so I've been commissioned to kind of go through some definitions as it relates to PE, review the diagnosis strategy, and also some evidence-based strategies for treatment of PE. So kind of getting into the catheter-based treatments for pulmonary embolism management beyond medical therapy alone. Um, so we'll begin with some objectives. As we talked about earlier, some definitions, I'll kind of go through it from an interventional cardiology perspective, proceduralist perspective. We'll develop an understanding of the diagnostic approach. I think that's fairly intuitive. for most of you. And then we'll also go through the review of risk stratification, and I'll kind of point out the new AHA, ACC categorization of PE as well. And we'll also go through the application of the evidence-based treatments for PE. So at a high level, in terms of pathophysiology for PE, it's obviously a thrombus in the pulmonary artery is unnatural. It provides an immediate pressure overload, and to Dr. Pugliese's point, it can impact that gas exchange pretty immediately. It evolves usually from a deep venous thrombosis, which can occur in the arms or in the legs. PEs can span all different types of severity. So you can have patients who have, for example, a CT scan for other non kind of PE related issues or unsuspectedly can be found to have a small pulmonary embolism. Usually those are subocclusive in small territories within the lung. They're usually clinically asymptomatic as it relates to a PE. They're not hypoxic, not tachypnic, and so on. And then they can range to presenting very severely with a high massive thrombus burden. Those patients who present with high massive thrombus burden are the highest risk patients. And clinically, that usually is related to the presence of RV dysfunction, RV strain, and low blood pressure, as we just talked about, which I'll explain a little bit further. So a little bit more in terms of pathophysiology. We just reviewed this just a few slides ago. But basically, our right ventricle is not used to that kind of a load on the right heart because it's a low pressure system, in general, in comparison to the left ventricle, which is much more muscular and a much more robust kind of chamber of the heart. So the right ventricle is very susceptible to the strain of a PE as it presents immediately. And so those patients can develop RV strain, and that can develop RV tension, and that tension on the wall of the right ventricle causes a whole cascade of events, as we just talked about, which can later cause LV compromise and low LV filling, both from the septum moving towards the left ventricle, but also because there's poor forward flow through the whole pulmonary circuit. And as that spiral continues, it's going to continue to happen, especially in the high risk patient, until the P is evacuated or treated. And it's for this reason that the patients who have RV dysfunction and actually have the highest mortality. And so, from a risk stratification standpoint, as we'll get to later in the next few slides, that's one of the highest predictors of mortality in patients who present with a pulmonary embolism. So, a little bit more detail on RV strain. The first time we usually find patients with RV strain are the times we diagnose it. So, that's with a CT scan in general for most patients. And the usual normal RV-LV ratio is usually around 1.0. Once the RV is dilated and expanded well beyond the left ventricle normal diameter, anytime it's above 1.0 in the presence of a P, that can carry about a 2 times higher 30-day mortality in patients who present with a pulmonary embolism. And unfortunately, as that strain increases, the mortality increases as well. Another kind of finding, if the CT kind of doesn't clinch the diagnosis of RV strain or it's hard to visualize because it's rotated or so on, oftentimes an echo can be helpful. And so the specific finding is a McConnell sign. We usually see that as the apex of the right ventricle in a four-chamber view basically is moving appropriately, but the rest of the RV free wall is not and is actually dyskinetic and often akinetic. And in those specific patients, in the setting of a PE, we call it a McConnell sign. It's a very specific finding of hemodynamic decompensation. So, in the presence of both findings, RV strain, a McConnell sign, and echo, we should have a very high index of suspicion that the patients are going to be very sick, and that should help us, triage those patients appropriately for treatment up front, and so on and so forth, which we'll talk about in the next few slides. Much like RV strain, hypotension is definitely linked to worse outcomes. So massive PE patients, which is generally defined as patients who have a lot of clot burden, but also have significant hypotension with blood pressure under 90, who need pressures and hemodynamic support. Those patients at least have a mortality of 50%. Those patients that don't have that are presenting, more mildly, still have a high mortality, but not quite as much. And if you follow those patients out long term, there's some data sets that support that mortality increases up to 71% and about 44% in the patients who present with submassive or lower risk PE. And as we just talked about, PE presents very commonly in hospitalized patients of the third most common causes of death. And despite our knowledge and understanding of the pathophysiology, it's often misdiagnosed or underdiagnosed. Um, and I think that's primarily because, we look for these clinical parameters, we look for dyspnea, we look for chest pain, tachycardia, hypoxia, hemoptysis, and even syncope, which is a very high risk feature. But that is sometimes sort of a masquerading of a pneumonia. How many times do you have patients who present with really sick sepsis or pneumonia or other kind of pulmonary ailments? And so if we remember what was just alluded to earlier from Dr. Pugliese's slides, immobility, recent surgery, venous stasis, patients who have underlying hypercoagulable conditions, people with a high inflammatory state can often have a venous thromboembolic event. So when you see that or suspect that in a patient and they have these clinical symptoms, I think we think of Virchow's triad in a more kind of clinical scenario. Every time we see these symptoms, we might think of the diagnosis more commonly and then order the appropriate workup. And as we talked about earlier, a CT scan is commonly done in most patients, but when that's not possible, a VQ scan is appropriate, and then, of course, an echocardiogram. From risk stratification, there's a lot of different literature out there. One of the most common pieces of literature is the PESI score, which is a little cumbersome when you really look at it, because this slide is actually, I tried to zoom in the best I could, but it's hard to really show all the features of it. But basically, the hallmarks are older patients presenting. So basically, after you have a PE diagnosis, if you're older, male gender, you have cancer, or you have the presence of some form of cardiopulmonary disease, you get sort of a higher score, if you will. That coupled with some hemodynamic changes like hypotension, tachycardia, etc., can put you at a higher risk category. That becomes more simplified in the simplified PESI score, which is a little bit more of a binary approach of looking at it. So if you have one of those variables, basically one or more factors makes you a higher risk patient. So definitely helpful, but not certainly not quite as strong as what the AHA is now coming out with a kind of a more granular approach in identification of P and categorizing patients. So you have the subclinical patients who present incidentally, as I alluded to earlier, and then as symptoms and clinical parameters change, like RV strain and the presence of biomarkers, hypotension and shock, those patients have a higher risk category. And so this is probably going to help us triage patients a lot more easily and identify patients who might benefit from our treatments. So in terms of some medical evidence, we can kind of go at a high level. I think the Pletho trial was one of them. So that looked at about 1,000 patients randomized to medical management versus medical management with heparin and anticoagulation with lysis. Um, in a sense, it was a positive study where we saw an improvement in hemodynamic decompensation and death initially, but it was sort of offset by the presence of a lot of bleeding, unfortunate bleeding, of course, and it kind of eliminated the benefit of what TPA offered, or excuse me, tenecteplase and lysis offered for these patients. And so beyond medical management, that's heparin, anticoagulation strategies, and TPA. I kind of think that's where the rationale for catheter-based treatments was sort of born to help reduce that RV dysfunction that is linked to higher mortality and hopefully in a more safer way to avoid bleeding. So we want to reduce that thrombus burden in a more immediate way, improve gas exchange faster, and hopefully avoid the downstream events of PE, which is chronic thromboembolic disease and recurrent PE and future VT events. Um, and I think personally, in my practice at least, as we've started to deploying and utilizing more catheter-based treatments, we're just seeing a lot more sicker patients. Primarily, I think because the awareness is out there for these treatments. So again, at a high level, there's a lot of data out there. There's a lot of new devices. So I think earlier on, maybe within the last several, decades, we've seen the deployment of these strategies where we're using sort of low dose TPA coupled with an ultrasonic catheter for catheter-directed lysis for treatment of PE. The Ultimate trial in 2014 randomized patients treated with anticoagulation versus this catheter-directed approach. RV-LV ratios actually improved quickly within a 24-hour period, and bleeding events were actually pretty low and safe in this study. The main caveat was that it was a small trial and not really powered for mortality, which we like to look for in cardiovascular research. The Seattle 2 trial, a little bit more robust, but single-arm prospective study, looked at the same thing with catheter-directed approach with ultrasonic treatment with ECOS. RV-LV ratio also improved, but the issue with that was a signal, small, but still a signal for some bleeding in those patients. Then later on, when the last like 5 to 7 years, we've seen a lower dwell time of the TPA treatment, and also looking at not only dwell time but the dose used for those patients who were treated. Still, the jury is out in terms of what the best strategy is for those types of treatments. But it's kind of operator dependent still at some point. But we've realized through these studies that you can do lower dwell times and lower doses to treat these patients and still achieve a robust improvement in RV strain. And unfortunately, again, these studies weren't really powered for mortality. More recently, we have the Peerless study, which was published in 2024. This was a randomized control trial utilizing mechanical thrombectomy, comparing it to catheter-directed lysis. Instead of looking at a kind of large composite endpoint, they sort of weighted this in a hierarchical fashion and calculated what's called a win ratio, and basically looked and heavily weighted factors such as death, mortality, length of stay, particularly in the ICU, as you can see here on the right-hand side, where mechanical thrombectomy actually allowed for a reduction in hospitalization and length of stay for those patients, and specifically in the ICU. Also, they saw less bailouts and clinical deterioration events in those patients. So again, I think based on these studies and really what's happening in the community all across this country and internationally, a lot of patients are being benefited by these treatments at this point. And so I think through that sort of evolution, and we can talk about this later in today's webinar, a lot of the recommendations have been kind of moving toward this by many professional societies. But I think we're seeing that the possibility of now allowing or offering an opportunity for patients to get treated when RV strain is present and there's biomarker elevations in as a minimum. And then for those level of severity patients, when they're, of course, more hemodynamically unstable, we're looking at those types of patients who might benefit. Whereas the less sick and less symptomatic patients with normal RV parameters and no biomarker elevations may not achieve that benefit and can be treated more easily with just anticoagulation alone, and certainly avoid the risk of procedure. So here's a case that kind of illustrates some of the benefits of looking through this, looking at PE through that lens, if you will. So a 58-year-old patient, typical risk factors, history of tobacco abuse, who presented suddenly with chest pain and shortness of breath, resuscitated, brought to the ER, was normotensive, but as you can see here on the left video, bilateral PE was present with evidence of RV strain. RV strain now can be seen more obviously on the echo on the right, where we see the RV is dilated, and that McConnell sign classically, where the apex is actually spared, but the RV is hypokinetic and dilated. So this is the procedural kind of what we see in the cath lab and in the IR space when we do these types of procedures. This is a pigtail catheter in the right lung. We usually start on the right side because that's the largest amount of lung to kind of treat initially. So you can see a filling defect in the right middle lobe and the right lower lobe in this patient. And after exchanging for a thrombectomy catheter, we were able to evacuate the thrombus with a couple pulls with a thrombectomy catheter and allow for restoration of flow within the right lung. We then turned our attention towards looking at the left lung, which had a lot of thrombus burden as well, as we saw on that CT scan. So the left upper lung here and the left lower lung was involved. We initially did a couple of pulls with the thrombectomy system, but had some challenges. So we took a smaller catheter, tunneled that down further into the lung, and we were able to evacuate the clot in this patient. Interestingly, these kinds of cases are super gratifying, especially when they go well. I mean, patients' oxygen requirements go down almost right away in the procedural suite. So this is just a depiction of what we found with this patient. Kind of thought clinically there was a lot more clot in the right lung, but there was a lot more on the left in this patient. We usually check PA pressures. If there's a really high PA pressure reading on a patient, we might think that's more of a chronic process and may not benefit from a thrombectomy. In this case, it was high normal, but we can see the mean pressure improved from 30 to 19 after we completed this procedure. And the echo actually shows a normalization of the RV function after the thrombectomy treatment. Here's another patient presented a little bit sicker. This patient actually just had a kidney transplant, presented with syncope, which, as we alluded to earlier, high risk feature clinically. We should have a higher index of suspicion for imminent issues related to that patient when they present with a PE. So high biomarkers, lactic acidosis, but interestingly, although presenting with a saddle PE, normotensive. And so she was behaving more of a submassive PE. And we could see RV strain as showed on the right there. Um, and this is the clot we had pulled out. This patient actually had a little bit higher pressures than that first patient I showed you, but the mean pressure improved from 44 to 23. Usually in the cath lab, I look for something anywhere between 10 to 15 millimeters of mercury improvement. But this patient got well very quickly in the procedural suite once we completed the procedure. So again, in terms of risk stratification, before these algorithms were developed by professional societies, I kind of thought of things in this way. And much like those last two cases I showed you, I used to be confused because some patients, when they present like a moderate or intermediate risk patient with normotension but high biomarkers and RV strain, it was still very difficult to treat them because sometimes they behaved more like a high risk patient, and as that last patient I just showed you with a saddle PE actually behaved clinically more like an intermediate risk, slightly lower risk patient, if you will. And so some of these things get kind of muffled when we categorize them too granularly. And so what we've come up with in our program locally is sort of this kind of a model where we categorize patients in this way, very similar to what we see in the new guidelines from the AHA, but looking at low-risk patients with similar parameters that were outlined, where they're normotensive, not requiring really any oxygen or minimal at all, with no evidence of RV strain or biomarker changes, and then categorizing them if they have any kind of abnormalities as higher risk, and then looking at those patients in that category of higher risk as either intermediate or high based on the presence of whether they have really significant hypotension or not, requiring pressors, looking at their ventilatory requirements, if any, and if the RV ratio is really severe in those patients. All patients in our program get called to the PERT call team, whoever the doctor is on call. We get the pulmonary team, the ICU doctors involved, and we decide on MCS needs, specifically ECMO, if those patients require it up front to stabilize them. As part of taking PERT call in our program, and when we have all these now operational kind of programs where we're checking for DVT, right, as a source for the PE, we're now identifying a lot of DVT patients. And so we have, as part of our algorithm, a treatment plan for those patients when necessary, as you can see down there. So here is a patient that actually is one of the higher risk patients you might find, morbidly obese patient who basically presented with saddle PE with severe RV strain from an outlying facility. Clinically, she was super sick. She had a lactic acid of 5.7, very high biomarkers, high O2 requirements requiring BiPAP, but her blood pressure wasn't 90, but it was definitely low in the low 100s. And so we decided to get the whole team involved. Obviously, the PERT team was activated. Myself, the pulmonary team, evaluated the patient, brought them down to the cath lab, intubated the patient to protect their airway, and basically, given the hemodynamic changes and biomarker changes we noted, put them on ECMO and offered them treatment with thrombectomy up front. So this is that patient. This is a pigtail catheter, which I usually begin with. We can see large thrombus burden involving the right upper lung and also the right middle lobe primarily. And this is a patient who's on ECMO, so some of the pictures are a little bit more sluggish and slow, if you will. It's not just lag on the webinar. So this is after a few mechanical thrombectomy pulls. We're able to open up the right middle lobe, still having some very small segmental branch involvement, but getting better perfusion. And then ultimately on the right side, you can see the upper lung was evacuated. And then this is a picture of the left lung. Again, a lot of thrombus burden involving both lobes in the left side. And ultimately, we had just like that previous case, we tunneled a catheter more distally to allow us to get the rest of the left lung open. So this patient did very well. Because we did this kind of in a calm way with all the team involved, actually were able to decannulate this patient without any surgical cut down or intervention. We did this percutaneously. So this patient did very well just after a couple days after the treatment. So in conclusion, Um, PE, as you can see, presents a very high mortality disease state. The presence of RV strain and dysfunction is a very clear predictor for worse outcomes. Risk stratification is very key in terms of outlining a treatment plan and decision making, especially in higher risk patients who present with a PE. And I personally think multidisciplinary approach with specialists like Dr. Pugliese, proceduralists like myself, can get you to the best outcomes for these patients. Catheter-directed therapies have been shown to be safe and effective. I think the current evidence for interventional procedures to address PE is very, very sound. I think it's only going to get better in the future. And so hopefully with this kind of categorization and new guidelines to support the practice of treating these patients will lead to more research and opportunity to improve outcomes for these patients down the line.
Thank you so much, Dr. Yallapragada, for that presentation and kind of walking us through all of those case studies. I am now going to bring back Dr. Pugliese to our webinar. We will go through some of the questions and just want to thank again Dr. Pugliese and Dr. Yallapragada for taking the time to go over all the information around pulmonary embolism care and how we could, learn more about the different treatments available. We're going to spend some time addressing the questions that we've received so far. If we're not able to address your question during this webinar, please don't hesitate to email us. We will be sharing our email address on the last slide, but let's get into it. So I see a question from Betty. She is asking, is ECMO required to do a thrombectomy? How long is someone left on it?
Um, I guess I'll take a stab at that first. It's not like ECMO traditionally is not something that is absolutely necessary for a thrombectomy case. The vast majority of PE patients will interface with that require treatment, probably won't require that kind of a thing, intervention. High risk patients, probably only represent about maybe 5%, maybe a little bit more of the population of patients that present with PE. Maybe in those patients you can consider it. What we found is that when patients are really unstable clinically, it might be better to stabilize them with mechanical circulatory support of some kind, like via ECMO, before consideration for procedure or treatment. But sometimes that's just the first part of the story, and you can treat them medically even after getting them stabilized on a support system like via ECMO. But certainly you don't have to have that in order to provide treatment. Dr. Pugliese, I don't know if you have
Yeah,
any thoughts
no,
on that.
I agree. Um, you know,
Thank you. I see a question from Dr. Jennifer Edwards. Thinking about PE as an inflammatory process, do you know if anyone has looked at statins, if patients are on statins might have a lower risk for first or recurrent PE or possibly a role in preventing post-PE syndromes?
um, maybe I can take that. I actually just don't know the answer to that question. I know it definitely has not been looked at in post-PE syndrome. Um, and then for recurrent PEs, outside of laboratory stuff, I don't know of any clinical evidence that has looked at that. I think just about post-PE syndrome, I mean, the thing with that is we don't really understand what that is, and that's probably heterogeneous. In other words, I think we generally lump them into three things. Either they have comorbidities, um, they're deconditioned, or they have some degree of chronic thromboembolic pulmonary disease. And so those are three actually different things. And so it's hard to I think we may unfortunately lump those three entities together into one syndrome. Yeah.
Yeah, I agree. I don't really have a good answer for that either, but it's an interesting question. Someone should study it. Yeah.
Yeah. Amazing. Thanks so much for answering that. We see another question in our Q&A. How do you typically manage patients that have RV strain but are otherwise completely hemodynamic stable? The evidence has demonstrated improvement in RV function, but longer term outcomes appear compared to anticoagulation alone?
No, I think
Yeah,
that's a very good question.
we could both take that. Go ahead. Yeah, go
Yeah,
first.
that's the hardest question to answer, actually, because most patients are going to present that way. I would say a large majority of them, at least. I mean, a lot of patients will have the biomarker changes very subtly. RV strain is seen in the majority of patients that will be, if that's their primary diagnosis, if you will, on presentation. So, um, clinically, it's a matter of what's going on with that particular patient for me. If they're requiring oxygen, sometimes I know that the intervention may not be immediate or necessary to be done right away. But based on their response, the first 24 to 48 hours on heparin or anticoagulation, I'll see. But I will generally say that I actually I'm a little bit more conservative, more as of lately, because if there's really no benefit in terms of outcome, why are we offering a treatment? Anticoagulation would suffice in most of those cases. But as some of these research trials that we reviewed showed us, length of stay becomes very important, and also the quicker recovery from them for the patient becomes important. So patients that we didn't really talk about this, but they'll have a lot of pleuritic pain. They may not be super hypoxic, but they'll be very uncomfortable. And you'll be surprised. Those are kind of on the lower spectrum risk patients. They can get through a thrombectomy procedure nowadays very quickly. And so, like I said, these are safe procedures to be done. It's not sort of a cowboy kind of intervention like we used to think maybe 10 years ago. So it's really patient specific, but I tend to offer the patient both choices, and jointly we'll make that decision together. I think that's the best approach personally.
Yeah, I mean, I agree with that for sure. And the way that, we get a lot of questions from like house staff and stuff about this. And the way I kind of think about RV strain and biomarkers, and I think particularly with biomarkers, many health systems have used like high sensitivity troponin. So now we're seeing and we, there's pretty good data to say that if you have a negative conventional troponin, but a positive high sensitivity troponin, that's really not of any clinical consequence. But we're typically not running both of those on the same patient, right? So we're encountering these patients that otherwise would have previously been, quote, low risk, and now the risk is elevated. And so really the way I think about it is if they don't have RV strain and their biomarkers are negative, I generally know I don't have to worry about them. Um, on the flip side, if they have evidence of positive biomarkers and RV strain, now I'm looking, as he talked about, I'm looking at other things like what does the patient look like? What are their vital signs? How did they respond to anticoagulation over the past 24 hours? And it's more the clinical features than I think help us most.
Thank you so much for answering that. This is a question for you both. How do you both foresee the new clinical categories and the 2026 guidelines changing your workflows and internal algorithms? What have your sites done so far in response to the new guidelines?
I'll let Dr. Pugliese answer that one first. I
Okay.
think it's going to change dramatically. I kind of want to, personally, I want to change our whole algorithm to look like that because I think it looks amazing. I'll let you go ahead.
Yeah, I think that um, one of the things is like communicating this to your hospital and your staff. I think what how I think what has been really important and for our health system, like for instance, we have 6 or 7 different hospitals, and I think many of you guys are facing with this, right? And so the care with regard to how people are thinking about PE at your like mothership hospital that has a million resources may be different than some of the other hospitals. And so I think what is really, really important, what a lot of people aren't thinking about, is we've been focused for a long time on RV strain, we've been focused on biomarkers, but I think this concept of normotensive shock, like making sure when patients come to the PE that lactate is part of the standard lab sets, like that maybe seem obvious for some, but many hospitals are not routinely drawing lactate in their PE patients. And so I think that's something that we're trying to standardize amongst our hospitals. And just because a patient's blood pressure is okay doesn't mean they're not in trouble. And so yeah, that's how I answer that question.
Yeah, I think you're absolutely right. I think one of the ways that the categorization, using that as a tool, and allowing you to risk stratify those patients, knowing when to call the PERT team. And I think to your point, if all of this is understood, when we treat patients, I'll have to think of it as a cardiologist for a moment. You have a patient in cardiogenic shock with a STEMI. We all know what that means. We know the time to door to balloon, and we have a really deep and kind of ingrained understanding. We don't need an algorithm to tell us really what to do in a sense, right? In some senses we do, but really, in the whether they need support or not. But in the PE space, this is still very new, right? We have transfer centers trying to bring a patient to our center, and if we don't talk in the same language, right? If my assessment of what it means to be class C1 is different from Dr. Pugliese at his program, we all have to kind of marry each other's kind of considerations and how we approach these patients and identify them and categorize them so that we can talk the same language in terms of treatment plan. And so I think that's what this classification will allow us to do. As long as it's penetrating and the hospital programs across the country can kind of adopt this, we'll all start thinking about it the same way and study it and treat it the same way, and really know when to escalate to the next program in the smaller facilities, right? To send to your program, to our program for these kind of treatments.
Yeah, the one thing I also wanted to piggyback, which is so important, is I feel like this classification system, while I do think there are important changes right now that are going to help in the health systems, you got to remember there are 7 randomized controlled trials that are going to be coming out in the next year. In fact, this week, in New England Journal of Medicine, High Pitho is gonna come out. It's going to be presented at ACC, and so all these trials, the data can be retrospectively abstracted and put in this classification system so you could see how those patients would have fit into our system. And so I think that when all this data comes out, we're going to have a much, much better idea of who we treat and who we leave alone.
That's a great point. I agree.
Yeah. Thank you so much for sharing that and answering that question. We have another question. Can we get your opinion on CPES score as a risk stratification, HR, RV strain, BNP, trope, central clot, DVT burden?
I can take that. I like the CPS score. It's been fairly well validated. I will say though, when I look at the components of the CPS score, I think many of us who've been doing this for a long time, like we're in our brains making this assessment every time. We're looking at the heart rate, we're looking at the RV. And so I think many of us are just using the CPS score in real time. Now, where I think this becomes helpful, where you might have certain thresholds for activation or for trainees and things like that, I think that's where that, comes into use. There was a really nice paper, it didn't include the CPS score, but by Jeff Barnes a couple of years ago that looked at kind of all the scoring systems we have, like BOVA and ESC. And essentially, what that paper shows is all those scores do predict kind of adverse outcomes, but the specificity predict that is actually pretty low. So I don't think personally any of these scores are really ready for prime time to say I need to do this or do that.
Great.
Yeah, I think it was a good first step kind of on our way to developing a classification scheme like we have now this year, because it did take some of those components into consideration. But like to your point, it's really that was more after you have the diagnosis and it was kind of more of a binary way to approach it. All of the classification schemes really don't get as granular. But yeah, I definitely agree with that.
Thanks so much for answering those questions. Um, Dr. Pugliese, I have a question for you. Given, and this could be also answered by Dr. Yallapragada, given what we know about provoked and unprovoked VT risk factors, where do you see gaps most commonly occurred in post-PE follow-up, and how might those gaps impact long-term outcomes?
Well, I think the biggest gap is we don't have enough dedicated post-PE follow-up. Like that's the gap. And I'm not saying like they don't need to come necessarily see someone whose entire specialty is post-PE follow-up. I'm just saying getting any kind of routine follow-up. So I think that's the first thing. And then there's just common things that we as like that we as a general kind of post-PE community don't do well. We're probably not prescribing enough DOACs. And we know the bleeding risk is lower. We're probably not dose reducing enough. We're probably prescribing too much aspirin plus DOAC in patients that don't need it. And we're probably not following the patients long enough and asking them specific questions about ongoing symptoms and screening them.
Yeah, I think those are important questions. I think the other big component of it is, oddly enough, you'll have patients with a PE, you'll have worked them up, you'll have treated them, sometimes offered them treatment like a catheter-directed treatment, and you're kind of stuck like, why did this happen to begin with? Well, they have some risk factors. Maybe they're a truck driver or they're very sedentary, and you think of Virchow's triad and such, but you're still like, well, I got to consider the other options of whether they have a hypercoagulable condition or maybe they have an occult cancer or whatever it is. There's no opportunity for that in the inpatient setting, and the follow-up is super key. So one of the to all of those points, I agree with Dr. Pugliese, but having a multidisciplinary approach, including a hematologist or a blood doctor on the team is going to be very key. We just kind of introduced that in our program over the last year, and it's been really important for the follow-up. I think when the team is big, the follow-up and the gaps in follow-up tend to be smaller. When it's just the providers, the pulmonary doctors in the ICU doing that, we just don't have the bandwidth, I think, to do it as a system. So the team needs to be expanded. The bench needs to be bigger to do that. But yeah, I absolutely agree.
Yeah, those are really great points. And I know something that we've been seeing with a lot of the hospitals that are participating in this initiative as well is having maybe a PE follow-up clinic or having a dedicated PE clinic. So I think that's definitely something we'll focus on in future educational events. So thanks so much for that response. I think we have time for a couple more questions. We have a question. With the new guidelines opening the door more for thrombectomies, what role does catheters or CDT play in your opinion, and how will high PIPO move the needle?
You don't want me to take that, do you, as a non-interventionalist?
You go first.
So these studies haven't been, presented yet, and so there are I say in my mind there are three randomized controlled trials that are potentially practice changing. They have the largest number of patients and they have the biggest aspect. So one is high PITHO, so that's CDT versus catheter thrombolysis versus anticoagulation. That's going to come out. That's going to come out this week at ACC, and then be published in the New England Journal of Medicine. We'll have to wait to see what those results are. And then the second two is one is going to be Peerless 2, which is almost finished enrolling. That's going to be the Inari FlowTriever versus anticoagulation. And then the third one is PE Tract, which is any kind of catheter-based device versus anticoagulation, but the outcome is long-term outcomes. And so those three trials, I think are going to completely have a potential to completely change how we treat patients. Um, me personally, as a non-interventionalist, I think that whether you choose mechanical thrombectomy or versus catheter-directed thrombolysis right now depends a lot on what the experience of your interventionalists are with those devices. It depends on the bleeding risk of the patients. There's a lot of factors that go into to these things that I see.
No, I mean, I echo all of that. It's going to be interesting to see how the next few years pan out. I personally, we all have our preferences. I think proceduralists, for whatever reason, I think it has to do with what we saw through the first peerless trial, where length of stay was dramatically, improved. But it really was a length of stay improvement type study, in terms of the design. It wasn't really powered for much more than that, to be honest. But I think there's been this kind of anecdotal feel that living through catheter-directed lysis treatment and Optolyse, and then going through lower treatment dwell times and all of that stuff, and then living through the development of thrombectomy tools for treatment of PE, there seems to be kind of amongst the procedure list a more of a preference to pursue that approach. And so I think it's because it allows for more immediate attention to the thrombus and immediate improvement. I also feel just practically, since we've developed PERT programs across the country, patients are developing or at least presenting with more high-risk PE, and it's because the patients that are coming to our program otherwise wouldn't have been captured. And now you're offering potentially a lysis strategy, whether it's systemic or catheter-directed, on a patient who's on MCS or a patient who's already very, very sick and extremis, and they're already going to be in DIC and other kind of medical issues will occur. And now you're going to give them lysis in some way, shape, or form, and that might cause issues. So I think there's a preference, just anecdotally for people to pursue more of an thrombectomy approach. But we'll see. It's going to be kind of an interesting next few years to see how it plays out.
Yeah, definitely. Thank you so much for answering that question and answering our questions during this webinar. We'll conclude the Q&A session now, but if anyone has any further questions for our two speakers, feel free to email our team directly, and we're happy to get them to the speakers. We'll also be sending some follow-up information post-webinar as well. But before we wrap up, we wanted to share a few upcoming events. We're hosting a follow-up healthcare professional connection forum that's going to be virtual on Thursday, June 4th from 11 a.m. to 2 p.m. Central Time. We'll be sending out the registration link in our follow-up email, so to keep a lookout for that. This is a half-day forum that will bring together innovative models and practices to improve PE identification and treatment, and we'll kind of continue with some of the discussion that we had today. Registration for this event is free, and again, will be sent to you post-webinar. And that kind of concludes our webinar for today. Thank you so much for joining the Clinical Fundamentals of Pulmonary Embolism webinar, presented as part of Targeted Pulmonary Embolism initiative, which is supported by Inari, now part of Stryker. Thank you so much for attending. When you exit this webinar, a brief survey will appear in your web. Please do fill that out. That feedback is greatly appreciated and will help us tailor future target PE education to your needs. If you have any questions at all, please feel free to email me or anyone else on our team. You also see Alexa's email for any questions that you might have. But we hope to see you all again at the virtual connection forum in June, and hope everyone has a great evening. Thank you so much to our speakers for joining, and thank you all so much for joining.
Good night, everyone.
Thank you.
Thanks, guys.